Tomer, thank you very much for inviting me to come. It's, well, it doesn't work on the slideshow, so I'll just show it like this. It's an honor and a privilege to be here amongst the, again, the stars in our field. And I'm hoping that in about 5 years, when we have this conference, it'll be the endometriosis, actually no, it should be the adenomyosis and endometriosis conference instead of just the endometriosis conference, because I think we've really missed the boat on adenomyosis, and I'm going to tell you why over the next 20 minutes. So Tomer gave me the title, Adenomyosis Dilemma, and boy, I could, as far as a dilemma, adenomyosis really fits the title. My disclosures are that I'm a consultant for Karl Storz Endoscopy and Medtronics, but those are on hysteroscopic equipment and it doesn't affect this particular talk. So why is adenomyosis so hard to understand? Well, there's variation in symptoms. We have no standardized histologic definition. We have no standardized radiologic definition. The diagnosis is most often made without a tissue diagnosis, and if you don't have tissue, that's going to influence your incidence, your prevalence, and risk factors. And we have no standard classification of the disease, so it's hard for us to communicate with each other as to what stage 1, 2, 3, or 4 disease. It's all descriptive. And as I know Dr. Griffith talked about yesterday, there's actually a paucity of research in adenomyosis in a condition that probably affects 15% of all women. And it presents with abnormal heavy bleeding, dysmenorrhea, back pain, dyspareunia, and infertility. And what's key for us now is that we have to now be cognizant of the disease. We have to be suspicious when patients come in and present with those symptoms that adenomyosis is a real possibility as a cause of their disease. And our problem has been over the last 30 years is that we treat what we can see. And if we can't see it, then we assume it's not there, and we're treating something else. And I was struck this morning when Dr. Redwan said, you know, I resect disease for the last 40 years or 50 years, however old you are, David, 60 years. And yet we don't do very well with dysmenorrhea. And we never really thought about why that is. So now with the advent of transvaginal ultrasound and helping us make the diagnosis of adenomyosis, we're really finding the disease in people we never thought had it. So again, you can't really use MRI as a good screening tool, but MRI is a good way to diagnose adenomyosis, and you see a thickening of the junctional zone, and that's very obvious right here. But now, over the last 3 or 4 years, led by people such as Katerina Exas-Kustos, we're just as accurate to make the diagnosis of adenomyosis or changes consistent with adenomyosis, I would say, just by transvaginal ultrasound. And it is so easy. So all we're really looking for in this is the same patient. You can see a retroverted uterus. You can see a thickened posterior myometrium, and it turns out to be a disease in the posterior aspect 70% of the time. And you can see cystic lesions. There are other changes that you can find in patients with adenomyosis, which include kind of a hockey stick endometrium, change in the vascularity. You can actually see the junctional zone on 3D ultrasound. So it is accurate in picking up adenomyosis about 90% of the time. Now, we are currently with adenomyosis where we were back with endometriosis in the 1970s when many of the surgeons in here started practicing. And in the 1970s, this is what V.Z. Buttram, who was a leader in the field out of Texas in 1979, he wrote this about patients who had endometriosis. He said, typically our patients with endometriosis appear to have an intense desire to excel. They are intense perfectionists, demanding and specific goals. They're usually well-dressed and have trim figures. Most are employed as secretarial positions, professions in law, medicine, and teaching. And once aware of an infertility problem, many patients have an obsessive desire to conceive. So the point was, who was getting diagnosed back then? You know, people, not everyone had the availability of laparoscopic procedures, but my suspicion is these are the patients who most likely got the laparoscopy, therefore we thought those were the ones at high risk for the disease. But we now know, and this is a slide from Linda, which includes Linda, you probably saw it yesterday, that endometriosis is not a disease necessarily of well-dressed white women in secretarial positions. That there's heterogeneity in age of onset symptoms, drug responses, comorbidities, and what have you, and we know that the disease takes on many forms. What's the clinical presentation of endometriosis? 50 to 90% of the patients have dysmenorrhea. They have dyspareunia. They have deep pelvic pain. They have low abdominal pain and back pain. They have cyclic bowel and bladder symptoms, and they have infertility. So essentially, any of these symptoms that intensify with the menstrual cycle are thought to be due to endometriosis. Now, I want you to tell me how these lesions here, which we know, and we heard again this morning, that this stage of the disease does not correlate with the severity of the symptoms. You tell me how these lesions here and these clear vesicles here cause dysmenorrhea. Tell me how they cause dyspareunia. Tell me how they cause abnormal uterine bleeding or heavy menstrual bleeding, and tell me how they cause infertility. Well, I can tell you with adenomyosis, if we just focus on infertility, that there's good data now, and that was published by Tulandi in the Fertility and Sterility, that patients with adenomyosis actually have lower implantation rates for undergoing IVF. They have lower clinical pregnancy rates if they're undergoing IVF, and they have lower live birth rates if they have adenomyosis. And it's actually a 41% decrease in the live birth rate. This has nothing to do with the endometriosis at all. It's a uterine disease. Now, I want you to think about adolescents. And adolescents now are probably the ones who are the most vulnerable to this misdiagnosis, because 15%, which is a huge number, 15% of adolescents miss at least one day a month from school because of severe painful periods. And as Dan Martin said, we don't tell these people it's normal to have that severe of painful periods. And when they go in and they have a laparoscopy, they see these clear lesions, and many times those clear lesions are not even biopsied, and the patients are told they have endometriosis, and then they're put on the birth control pill, or they're put on Mirena, or they're given some hormonal therapy and told that that's what's causing their severe dysmenorrhea, never having an ultrasound to look for other causes. We know that 92% of these patients have stage 1 or stage 2 disease, and there's a 56% recurrence of symptoms, even if you resect it within 5 years. So this is a 17-year-old patient who came to my office, and we did a transvaginal ultrasound, which I admit in a younger patient can be difficult, but she happened to be sexually active. And you can see in the posterior wall in this patient, you can see cystic adenomyosis. And I would say that if you think about it, she had severe dysmenorrhea, it makes sense that she's going to have a uterine disease. You have to think about it, and often if you ask them, they will have heavier than normal periods, and they will often, if they're sexually active, they'll often have dyspareunia. And it's not just the younger patients. So this is a study published by Francisco Carmona, looked at 155 women who had deep infiltrating endometriosis and also had adenomyosis. And there was a positive correlation of adenomyosis to pelvic pain, rectal bleeding, dysuria, and hematuria, and not a positive correlation with the deep infiltrating endometriosis in this particular study. So I say, when you think about the risk factors for adenomyosis, what are we taught? We're taught it happens to women in their 40s. We're taught that they're at higher risk if they've had multiple children. And why is that? Those are risk factors not for adenomyosis, I'd say. Those are risk factors for the patient who are going to have a hysterectomy. And that's the time that most of these people are getting diagnosed, at the time of hysterectomy. And I think we've missed the disease early on in their adult life. So I want to avoid the mistakes that we've made with endometriosis. With endometriosis, we know now that on average, it takes up to 4 years to get a diagnosis. We're trying to make the diagnosis of endometriosis, and I feel terrible that ASRM as well as ESHRE have said that you can make the diagnosis of endometriosis now without even a biopsy, and I think that's a disservice to our patients. We always assume that we could see and excise all the disease, and we've heard today that we know that's not the case. We also assume now that the best the best therapy is non-surgical and hormonal, and I would say that that may not be the case as well. We have a lack of understanding of how and why the disease has such varied phenotypes, and for years and years and years, we've accepted the unknown, which we've heard today. Stage 1, stage 2 disease does not correlate with the symptoms. We can't accept that. We have to understand why that is. Now, it's interesting. I'm glad we have a pathologist in the room. I went downstairs to our pathologist's office in Boston, and I said, show me the textbook that you actually find is the best textbook for pathology of the female reproductive tract. And there's an entire textbook written, edited by George Mutler at Brigham. And out of 400 pages in this entire book on the female reproductive tract, there is one full page on adenomyosis. So you can't necessarily blame the pathologist for not knowing a lot about adenomyosis. There's really not much written, even in the pathologic literature. So what is the definition of adenomyosis? Well, I think we can all agree that its ectopic endometrium must be located past the last glands of the basalis. Now, there are several definitions in the literature, and all of these have been used in the literature. Greater than 1 high power field, greater than 1 low power field, 2.5 millimeters or more. But my favorite was when I went down to Newton Wellesley to the pathologist, and he says, I know it when I see it, which makes it hard to study. And there's a variation in the prevalence because we have a variation in the diagnosis, in the histology. So, if you look at the histology of the endometrium, we think, oh, it must be easy to measure greater than 1 high power field below the endometrial myometrial surface. Well, it is in this particular circumstance, but this is also common. And here you see glands that extend. It's not a smooth border. There is no basement membrane between the endometrium and myometrium. So you would look at this and say, is this lesion should be measured from here to here or here to here? It's not an easy disease to diagnose. And the one last thing I want to clear up is that we talk about the junctional zone. The junctional zone is a radiologic phenomena. It's not a histologic phenomena. The uterus does have 2 layers of myometrium. There is an inner myometrium and an outer myometrium. The inner myometrium is Mullerian in origin. The outer myometrium is non-Mullerian and is mesenchymal in origin. But that is the inner myometrium is not, I repeat, is not the junctional zone. The inner myometrium is hormone responsive, it varies in thickness, and is not necessarily smooth. So if you look here again, you can see that if you look at the inner myometrium and we know that it gets thick and thin and it changes throughout the cycle, you could say, is really these leftover glands that are in this inner myometrium, are they a result of kind of a rising tide that happens throughout the cycle? And again, here's the junctional zone. This junctional zone is not necessarily the endometrium. I asked the pathologist, if you were to biopsy the inner myometrium and do histology here versus the outer myometrium, could they tell you the difference? And the answer at my institution was no. They could not look at it histologically and tell you if it's from the inner or the outer. So why does the junctional zone have its characteristic appearance? And what does that have to do with adenomyosis? We do know that when it's thick, that these patients have higher incidence of pain, bleeding, and infertility. And no one really knows, not even the radiologist knows why the junctional zone on MRI shows up thick as it does. And there are theories there, and these are all theories as to why the junctional zone lights up the way it does, but no one has a real answer. But for this audience, what's clear, what I want to make clear, is the junctional zone does not necessarily equal the inner myometrium. Now, lastly, before I close, I think where we're going in the future is what some of the things that you've heard about today is that we shouldn't be treating everyone as if this is one disease, as if you can put them on a GnRH agonist or an antagonist or a continuous pill and expect that we're actually treating disease. We need to understand the molecular mechanisms of the disease. And working with Linda and her group has taught me so much about our bodies being systems, and they're not individual proteins. They're not kinases. They're not, they all work together as a system. And any particular lab who may have an interest, and we've seen this over the years, we say, okay, in patients with endometriosis, there's elevation of VEGF. Therefore, that's what's causing the endometriosis, or changes in your HOX10 or something like that, where there's certainly not one change that's going to explain this disease. These are all interrelated, and this is why you have to use, I feel, systems biology to understand the system if we're going to make any progress on adenomyosis and endometriosis. And what we're doing in our lab, and this is work by Evan Cheswick, who's a postdoc in Linda's lab, is that we're taking adenomyotic tissue, trying to look at over 50 cytokines and proteins and look at them and see if there's something unique about the myometrium of patients with adenomyosis. When you do that and you apply a mathematical model, you can find some groupings, particularly in the metalloproteinases, and then maybe over time, if you stain for those metalloproteinases, and I just threw this in here because Dan Martin says he likes color. So Dan, this is slides for you. But if you stain, maybe you'll be able to find something in the biology where we can interrupt that pathway and not treat everyone with the same hormonal therapy. And again, this is what Linda's doing, and she showed this yesterday. We can't even study the endometrium or the myometrium by itself because it's affected by the other organs within the body, and it has to be perfused. And as you know, with the bone marrow and the stem cells and everything else, we have to have systems like this if we're really going to make any headway on understanding the disease. And these were all not supposed to be shown. But lastly, I've got 43 seconds. The last dilemma with adenomyosis is there a role for surgery? I don't want to get into the laparotomy and the laparoscopy, but I will say that certainly in Europe, this is being done a lot more than in the United States. And at least for uterine-sparing surgery for adenomyosis, they're reporting very, very good pregnancy rates up to 70, 80%. None of this is randomized or prospective. It's all retrospective, so you take it with a grain of salt, like most surgical studies. This is a very interesting patient of mine who's 37 years old, who had 3 recurrent losses, and she actually had some dyspareunia but didn't have many other symptoms, and she's an infertility patient. We did the MRI and the ultrasound, and you can see the adenomyosis located in this. In her, it happens to be in the anterior wall right here. So we actually took the hysteroscope And as you resect it, what's so cool, you can actually, as you go deep, you see the smooth muscle hyperplasia, and you can see actually the glands here that are deep within the myometrium, and these look like fresh glands right out of the endometrium, and again, it was fairly deep. And you know, what's the best way to resect this? It's hard, we don't have the answers. Once you resect it, again, unlike a fibroid will displace myometrium. This is actually invading myometrium, so I don't know how it's going to heal. And the goal was not only to resect all that glandular tissue that you see deep in the myometrium, but to resect all that smooth muscle hyperplasia until we got down to a normal myometrium. So these are techniques, again, that are of interest with absolutely no data as to their efficacy, but because she had had such a poor reproductive history, it seemed like it was worth to try. And I'm almost done.
How long did it take?
To do that whole thing, about 30 minutes. So, and again, we need to work with our pathologist to make the diagnosis of adenomyosis. Most pathologists, at least in our institution, they do approximately 6 blocks per uterus. And so, and I'm suspicious of adenomyosis, I go talk to them, I tell them the clinical history, and they'll do up to 15 blocks. And we find the disease at least double the prevalence when I talk to the pathologist than when I don't talk to pathologists. So they know what to look for. Thank you very much for your attention.